Cirrhosis is when chronic inflammation and liver damage causes the liver to become fibrotic and develop scar tissue. At a cellular level, the hepatocytes become impaired, and this leads to hepatic dysfunction and portal hypertension. Cirrhosis is usually irreversible, so it's usually called end-stage or late-stage liver damage, and often requires a liver transplant. However, in some cases, early treatment can slow down and even reverse the cirrhosis. Compensated cirrhosis is when there's enough healthy cells to make up for the damaged ones, but minor complications like hemorrhoids can still happen. Decompensated cirrhosis is when healthy cells can no longer keep up with the workload, causing major complications like hepatic encephalopathy, ascites, and esophageal and gastric variceal hemorrhage. In compensated cirrhosis, although there aren't many major complications, there might still be some symptoms like loss of appetite, fatigue, and muscle cramps. There might also be easy bruising and excessive bleeding because there aren't enough clotting factors produced by the liver. Cirrhosis can also impair estrogen metabolism, causing amenorrhea and irregular menstrual bleeding in females, and low libido and gynecomastia in males. On physical exam, there might be hepatomegaly, where the liver can feel firm and nodular. But when there's lots of scarring, the liver might be small, so that it can't be felt at all. Another sign is spider angiomas, or spider nevi, which are swollen blood vessels just beneath the skin surface on the trunk, face, and upper limbs. Palmar erythema, which is redness of the hands, can sometimes be seen as well. There can also be hypertrophic osteoarthropathy, which is when there's nail clubbing and periostitis, which is inflammation around the small hand joints. Sometimes there are Dupuytren contracture, which is when one or more fingers are permanently flexed. Portal hypertension can lead to splenomegaly, along with caput medusae, which are distended and engorged paraumbilical veins on the surface of the abdomen. Finally, there might be minor complications like hemorrhoids identified on a digital exam. In terms of diagnosing cirrhosis, lab work includes a CBC, which most commonly shows thrombocytopenia, especially if there's also splenomegaly, but can also show anemia and leukopenia. Markers of liver injury are AST, ALT, alkaline phosphatase, and GGT, and they're usually elevated. Total and conjugated bilirubin are usually normal in compensated cirrhosis. Finally, markers of liver function like albumin can decrease as cirrhosis progresses, and PT, PTT, and INR can increase as cirrhosis progresses. In addition, FibroSure or FibroTest is done using alpha-2 macroglobulin, haptoglobin, total gamma globulin, apolipoprotein A1, GGT, and total bilirubin to generate a score that estimates liver fibrosis. An abdominal ultrasound shows surface nodularity and increased echogenicity, and sometimes there's atrophy in the right lobe and hypertrophy of the left and caudate lobe. If there's portal hypertension, then the diameter of the portal vein is over 13 millimeters. There's also ultrasound-based elastography, which measures tissue elasticity. Normal liver elasticity ranges from 2.6 to 6.2 kilopascals, and when it's above 7 kilopascals, that means that there's significant fibrosis. And when it's above 11 kilopascals, that means there's cirrhosis. A liver biopsy is the gold standard for diagnosing cirrhosis, and also finding the cause. But it's not always done, especially when other findings strongly suggest cirrhosis. If it is done, a liver biopsy will often show bridging fibrosis and irregular nodules of regenerating hepatocytes. Individuals with cirrhosis should avoid alcohol, medications that are hepatotoxic, like acetaminophen, and also herbal and dietary supplements that can damage the liver like germander. Individuals should also be vaccinated for hepatitis A and B if they're not already immune. Doses of certain medications like tramadol, which is an opioid pain medication, may need to be adjusted to prevent further harm to the liver. Individuals with cirrhosis should be monitored every 3 to 6 months using a CBC, markers of liver injury, and markers of liver dysfunction. In addition, an ultrasound should be done, and alpha-fetoprotein levels can also be checked to monitor for possible tumors, since cirrhotic individuals are at increased risk for developing hepatocellular carcinoma. Alright, now with decompensated cirrhosis, there are major complications, which might be triggered by things like acute infections, alcohol intoxication, constipation, or even bouts of dehydration. Treatment for these complications starts with resolving the triggering event, like treating the infection or abstaining from alcohol. One major complication of decompensated cirrhosis is jaundice, which can happen because the liver is unable to conjugate bilirubin. Lab findings would show total bilirubin levels over 2 milligrams per deciliter. Another complication is hepatic encephalopathy, and this happens because the liver is unable to effectively remove toxins, like ammonia, from the blood. These toxins can build up and get into the brain, causing symptoms like insomnia or hypersomnia. As toxins accumulate, there can be mood changes, along with confusion and even coma in some cases. On physical exam, there might be asterixis, a flapping tremor of the hand that appears when the wrist is extended, like a bird that's flapping its wings. Lab findings show high levels of ammonia, and it can be lowered using lactulose given orally or through an enema. Lactulose is a non-absorbable sugar that decreases absorption of ammonia in the intestines and prevents constipation. If the individual doesn't improve in 48 hours, then oral rifaximin is given. That's an antibiotic that kills ammonia-producing bacteria in the intestines, and also has anti-inflammatory properties. Individuals with recurrent hepatic encephalopathy can be given ongoing treatment with lactulose. Now, although portal hypertension can be seen in compensated cirrhosis, as things worsen, it can lead to major complications that are seen in decompensated cirrhosis. Portal hypertension can cause peripheral edema as well as a buildup of excess fluid in the peritoneal cavity, resulting in ascites. Ascites can cause abdominal distension, as well as shifting dullness on percussion and a positive fluid wave test. Additional lab work for ascites includes electrolytes in order to identify any imbalances, especially hyponatremia. An abdominal ultrasound can confirm the diagnosis. Usually the fluid in ascites appears anechoic. Next, a paracentesis is done to collect acidic fluid. The acidic fluid is typically crystal clear, and bloody acidic fluid suggests a tumor. A cell count and differential is also done, and with normal acidic fluid there are below 250 neutrophils. In addition, total protein levels are below 3 grams per deciliter, saying that the fluid is a transidate, while an exudate has more than 3 grams per deciliter of protein. Next, the acidic fluid is tested for albumin to calculate the serum to ascites albumin gradient, or SAG. A SAG above 1.1 means that portal hypertension is present. Because salt helps retain water, treatment of moderate ascites includes sodium restriction to 2 grams per day. In addition, a combination of diuretics like spironolactone, a potassium-sparing diuretic, and furosemide, a loop diuretic, is commonly used to get rid of excess fluid. Individuals without peripheral edema typically lose about 0.5 kilograms daily, and individuals with peripheral edema lose about 1 kilogram daily. As the ascites resolves, the diuretics are tapered and then stopped. If an individual develops hepatic encephalopathy or has severe hyponatremia, with sodium levels below 120 milliequivalents per liter, then diuretic treatment is stopped and serial paracentesis is done to reduce the ascites. In severe hyponatremia, fluid intake is restricted to less than the urine volume. Treatment of severe ascites is done using large volume paracentesis, where up to 5 liters of fluid is taken out of the abdomen at one time without causing hypovolemia. When more than 5 liters of fluid is taken out, albumin is given afterwards. A major complication of ascites is spontaneous bacterial peritonitis, or SBP, which is an infection of the acidic fluid. It can cause severe abdominal pain, fever, and an altered mental status. A paracentesis of the acidic fluid is done, and the fluid looks turbid or cloudy. The cell count is over 250 neutrophils per millimeter square, and total protein is above 1 gram per deciliter, and the SAG is above 1.1. In addition, the glucose is usually above 50 milligrams per deciliter, which distinguishes SBP from a secondary bacterial peritonitis, where glucose is below 50 milligrams per deciliter and the LDH is below 225 international units per liter. Cultures and gram stains are also sent, With SBP, there's a single pathogen found, and the common are Escherichia coli, Klebsiella pneumoniae, and Streptococcus pneumoniae. Whereas with secondary bacterial peritonitis, multiple pathogens are usually involved. Empiric antibiotics for SBP are IV cefotaxime. Another major complication of portal hypertension is variceal hemorrhage, specifically bleeding from dilated veins in the esophagus and stomach. Esophageal and stomach variceal veins are usually seen on an upper endoscopy, which is usually done within 12 hours of the bleeding. During that procedure, variceal ligation or endoscopic sclerotherapy can be done to help stop the bleeding. In addition, IV octreotide, which is a somatostatin analog, is used to help decrease portal blood flow. If there's a massive bleeding, or if endoscopic therapy fails to stop the bleeding, then balloon tamponade is done using a Blakemore tube. This applies direct pressure on the esophagus. If endoscopic approaches fail, a transjugular intrahepatic portosystemic shunt, or TIPS, procedure can be done, which creates a path between the portal and systemic circulation in order to lower the portal pressure. In moderately ill individuals, IV ciprofloxacin is given for a week to prevent an infection, and in severely ill individuals, IV ceftriaxone is given instead. Given the risk of bleeding, it's important to spot varices early on. So in compensated cirrhosis, an upper endoscopy is done every 2 to 3 years, and in decompensated cirrhosis, it's done every year. Individuals with varices should have endoscopic variceal ligation done, and those at high risk, like individuals with decompensated cirrhosis, should get prophylactic beta blockers, like propranolol, which reduce portal vein pressures. Individuals with a history of ascites, or SBP, or variceal hemorrhage are given trimethoprim sulfamethoxazole as antibiotic prophylaxis. Two more complications, hepatorenal syndrome and hepatopulmonary syndrome, describe failure of the liver and kidneys and failure of the liver and lungs, respectively. They occur because portal hypertension causes arterial and capillary vasodilation, which reduces systemic vascular resistance and can damage the kidneys and lungs. Alright, now let's switch gears and talk about hepatocellular carcinoma, which is a primary liver tumor that often occurs in cirrhosis. In some cases, there's a paraneoplastic syndrome, with symptoms like hypoglycemia, because the tumor consumes a lot of glucose, diarrhea, caused by vasoactive peptides that increase intestinal secretion, and hypercalcemia, due to secretion of parathyroid-like hormone. Lab findings can include high levels of alpha-fetoprotein, and if there's a paraneoplastic syndrome, there can be a hypoglycemia and high levels of calcium. If there's diarrhea, there might be hyponatremia or hypokalemia. An ultrasound would show a hypoechoic mass in the liver, and an abdominal CT scan can help stage the tumor using the tumor node metastasis system. Finally, a liver biopsy can be done that typically shows broad tuberculi and pseudoglands. Common sites of metastasis include the lungs, intra-abdominal lymph nodes, and bone. Depending on the location and spread of the tumor, a partial hepatectomy or a liver transplant might be done. If the tumor cannot be surgically removed, then ablation and embolization or chemoradiation can be done. If lymph nodes were invaded or if there's metastasis, then medications like sorafenib or lenvatinib can be used to slow tumor growth and relieve the symptoms. Now let's talk about the underlying causes of cirrhosis. First off, there's chronic viral hepatitis, which is usually due to hepatitis B or C infection that lasts for over 6 months. With chronic hepatitis B, HB-SAG and anti-HBC antibodies are positive. And with chronic hepatitis C, anti-HCV antibodies are positive and there are elevated levels of HCV RNA. Next, there's alcoholic liver disease, caused by drinking over 30 grams of alcohol per day, or more than 3 beers daily. And non-alcoholic fatty liver disease, or NAFLD, which is associated with metabolic syndrome, which includes obesity, arterial hypertension, insulin resistance, and dyslipidemia. Both of these lead to steatosis, which is the infiltration of liver cells with fat, and steatohepatitis, which is when there's a fatty infiltration along with inflammation. When NAFLD causes steatohepatitis, it's called non-alcoholic steatohepatitis, or NASH. With alcoholic liver disease, lab findings can show anemia and an elevated MCV, suggesting vitamin B12 or folate deficiency due to alcohol toxicity. The ESR can be elevated, and AST to ALT ratio is above 2. With NAFLD-induced hepatic steatosis and NASH, other causes of hepatic steatosis need to be ruled out, like alcoholic liver disease and viral hepatitis. Next, an ultrasound is done, and the liver typically appears hyperechoic, with both alcoholic and non-alcoholic liver disease. On an abdominal CT scan, the liver composition is compared to the spleen. A fatty liver has an attenuation that's at least 10 Hounsfield units lower than the spleen. On a liver biopsy, in steatosis, there's fat accumulation, and in steatohepatitis, there's neutrophilic infiltration. Treatment relies on alcohol abstinence, and with NAFLD, it requires management of metabolic syndrome. Hemochromatosis is a hereditary disorder caused by a mutation in the HFE gene, which leads to increased iron absorption. The excess iron gets deposited in the liver, heart, pancreas, and pituitary. In advanced stages, individuals have a classic triad of cirrhosis, diabetes mellitus, and skin pigmentation. The latter two are lumped together in the term bronze diabetes. Lab findings include a serum transferrin above 45%, and disease confirmation is done with genetic testing. Treatment consists of reducing iron load and phlebotomies that remove up to 500 milliliters of blood weekly for 50 weeks, and after that every 2 to 4 months. Autoimmune hepatitis is a condition where circulating antibodies attack liver cells. Lab findings include an elevated total gamma globulin level, especially IgG, anti-nuclear antibodies or ANA, anti-smooth muscle antibodies, anti-liver kidney microsomal 1 antibodies, and anti-mitochondrial antibodies. Autoimmune hepatitis is often associated with other autoimmune conditions, like autoimmune thyroiditis. Initial treatment is typically done with oral glucocorticoids, like prednisone, and once there's remission, meaning that liver injury markers normalize and there are no symptoms, prednisone or azathioprine can be used for maintenance therapy. Primary sclerosing cholangitis is a progressive disease in which there's inflammation, fibrosis, and strictures of the medium and large ducts in the intra and extrahepatic parts of the biliary tree. Sometimes there's an elevated total gamma globulin level, especially IgM. Paranuclear anti-neutrophil cytoplasmic antibodies, or p-ANCA, can also be high. Next, an ultrasound is done, and this shows bile duct wall thickening and focal bile duct dilations. Diagnosis is confirmed by MRCP, where the biliary ducts are beaded or have a pruned tree appearance, meaning that there are multiple strictures. If an ERCP is done, then a biopsy can be performed that shows onion skin fibrosis due to periductal fibrosis. Treatment is done using ursodeoxycholic acid, which is a bile acid, that stimulates hepatobiliary secretion and protects hepatocytes from being destroyed by bile acids. The only treatment for primary sclerosing cholangitis is a liver transplant. Primary biliary cholangitis, sometimes called primary biliary cirrhosis, is an autoimmune condition in which the epithelial cells lining the intrahepatic biliary ducts are gradually destroyed. There can be distinctive skin changes like hyperpigmentation, as well as lesions like xanthomas and rashes that show dermatographism, which means that it looks like someone has written or drawn on the skin. Lab findings include elevated cholesterol levels, anti-mitochondrial antibodies, which are the key finding, and sometimes anti-nuclear antibodies are also present. An ultrasound or MRCP can be done to rule out an extrahepatic obstruction. If a liver biopsy is done, it shows inflammation, abnormal connective tissue, or fibrosis in the portal and periportal areas. Treatment is done using ursodeoxycholic acid. The only curative treatment is a liver transplant. Wilson disease is a genetic disorder that leads to excessive copper deposition in the liver, eyes, and brain. Neurological symptoms include dysarthria, ataxia, dystonia, tremor, and Parkinsonism. There can also be psychiatric symptoms like depression and personality changes. An ocular slit lamp examination shows Kaiser-Fleischer rings, which are dark rings around the iris. Lab findings include ceruloplasmin levels below 20 milligrams per deciliter. That's the protein that transports copper. In addition, a 24-hour urine copper test shows over 100 micrograms of copper in the urine. Treatment includes avoiding foods with a high copper content like nuts, chocolate, and mushrooms. Treatment can also include chelators that can bind to excess copper like D-penicillamine and trientine. Alpha-1 antitrypsin deficiency is a genetic disorder that affects the lungs and the liver. In the lungs, there's excess protease activity that results in destruction of elastin, resulting in emphysema. In the liver, the abnormal alpha-1 antitrypsin protein accumulates and causes inflammation. Lab findings include alpha-1 antitrypsin levels below 11 micromoles per liter. Next, isoelectric focusing can be done. This separates molecules based on their isoelectric point and can identify different alpha-1 antitrypsin variants. PCR can be used to identify the different alpha-1 antitrypsin variants. Pulmonary treatment is done with inhaled bronchodilators, like salmeterol, and prevention relies on avoiding smoke exposure. And there's no specific treatment for this liver disease. Alright, as a quick recap. Cirrhosis can be compensated, in which the individual is asymptomatic or presents nonspecific symptoms. A workup includes a CBC that can show thrombocytopenia, anemia, leukopenia, markers of liver injury like AST, ALT, alkaline phosphatase, and GGT, which are elevated, and total and conjugated bilirubin, which can be normal. Markers of liver function like albumin can decrease as cirrhosis progresses, while PT, PPT, and INR can increase as cirrhosis progresses. An ultrasound is done next, along with FibroSure, ultrasound-based elastography, or a liver biopsy, which is the gold standard for diagnosing cirrhosis. With decompensated cirrhosis, major complications are present. First, there's jaundice, where total bilirubin levels are over 2 milligrams per deciliter. With hepatic encephalopathy, there's asterixis and high levels of ammonia. Treatment relies on eliminating precipitating factors, as well as lactulose and rifaximin. Another complication is severe portal hypertension, which often leads to ascites, that's usually treated with sodium restriction and diuretic therapy, SBP, that's treated with IV cefotaxime, and esophageal and gastric variceal hemorrhage, that's treated with endoscopic variceal ligation or endoscopic sclerotherapy, or TIPS, and prevented with propranolol. And finally, it can also lead to hepatorenal syndrome and hepatopulmonary syndrome. One complication of cirrhosis overall is hepatocellular carcinoma, which can be monitored with an ultrasound every 3 to 6 months. A CT scan is done to confirm the diagnosis and stage the condition using TNM system. Treatment depends on the extent and location of the tumor.